Welcome to the forum at the Kennedy School of Government. I'm Julie Wilson, and it is my privilege today to introduce Sheila Burke, who will then introduce the rest of the panel. This being sort of Harvard, we all introduce one another down the line. But on the behalf of the Malcolm Weiner Center for Social Policy, the Rappaport Institute for Greater Boston, the Health Policy Professional Interest Council, which is the 200 or so students from around the university who are focusing on health policy in terms of careers and studies, and particularly the Kaiser Family Foundation, which generously funded this, I would like to welcome you to a discussion of Massachusetts healthcare reform and what this means for healthcare reform nationally. Sheila Burke, who will be moderating the panel, is a member of our faculty and also an alum of the Kennedy School of Government. She's done many things in her distinguished career. I'm going to focus only, however, on her health policy and health experience. Sheila is a nurse. She then moved on through a series of jobs to the Senate, where she was Bob Dole's chief of staff, eventually becoming the secretary of the Senate. And she specialized in healthcare policy, among other issues, during that period of time. Since then, she's been our executive dean. She's worked at the Smithsonian, but even more importantly for tonight's conversation, she sat on MedPAC for a number of years. She's been on a number of foundations, she's on a number of boards, and she has headed a number of Institute of Medicine committees on various issues of healthcare reform. There are few people on our faculty who are as knowledgeable as Sheila, and those who are sitting right there in the front row. So Sheila.
Thank you, Julie. Let me join with Julie in welcoming all of you, and our thanks to all the folks that contributed to the panel this evening, but particular thanks to the Kaiser Family Foundation, who provided the support for tonight's panel, as well as for the activities we had during the course of the day to talk about Massachusetts. Your presence here confirms what I think we all know and believe, and that is there is an enormous amount of interest in healthcare reform. It is an issue of particular concern and personal interest to people across the country. And of particular note in this time frame because of the discussions going on both here in Massachusetts as well as nationally. This afternoon, some of us had the opportunity to meet and chat and talk about the Massachusetts plan in some detail. The first panel was, and I'll read the title of the first panel, was the Massachusetts Plan, Cost and Sustainability, the Canary in the Tunnel. Well, tonight we're going to examine the canary, and we're going to look at, in fact, what that canary found in the tunnel. The American public continues to identify healthcare as one of the issues they care deeply about. President Obama, federal lawmakers have really across the political spectrum have called for reform in our system. But is always the case with healthcare reform. That is true today, as it was true in the 90s, and has been true in all previous administrations that have attempted to deal with this issue. There are a predictable number of very complex policy, management, economic, and legal issues that have to be dealt with. A dialogue about healthcare reform, however, is absolutely critical today. Certainly the growing number of the uninsured and the underinsured, the escalating number of working adults with chronic conditions that are not being managed, and there are increasing costs of their care. And again, while we have a combined system of public financing and public entitlement programs, as well as private insurance, individuals who are either ineligible for those public programs and don't receive insurance through their employers are facing increasingly few affordable options to access coverage. And we know, all of us know, that being either underinsured or being uninsured affects the health and the well-being of not only ourselves, but of our nation in terms of our society and the kinds of things that we can do. So many believe healthcare reform ought to be comprehensive. And we've seen a number of those kinds of plans discussed that take on all of the issues that we're confronting in terms of coverage, in terms of cost, in terms of quality, and trying to improve all those issues. Others will seek only incremental steps with a view towards steps forward while making progress, make it politically feasible to try and put those changes in place. But all of us increasingly, certainly people at the federal level, are looking to the states as incubators, as the opportunity to look at how system changes have been played out and how, in fact, they have been enacted. It has been 3 years since Massachusetts enacted landmark legislation providing coverage to its citizens. They chose to do so using individual mandates, using employer participation, the creation of an exchange, the presence of a public program, all built on earlier reforms of the insurance market. Circumstances that were quite unique to Massachusetts and are not necessarily present in the rest of the states across the country. They are clearly facing some challenges as they meet this 3-year mark. In fact, I think the anniversary was a week or 2 weeks ago. It's been that recent. But they've also seen real success in the coverage of people in this state. 97%, I believe now, are in fact covered by some form of insurance in the state of Massachusetts. So the question for us this evening is whether this is the direction the country ought to go. Have they, in fact, given us a model upon which we should build, or have we learned things from that model that we might want to avoid, or, in fact, try not to have recreated in any kind of national reform? So tonight, we have 3 people with us who are uniquely qualified to talk about these issues. John Kingsdale, who will be first, is the Executive Director of the Commonwealth Health Insurance Connector Authority, previously a Senior Executive at the Tufts Health Plan. Gail Walensky, a Senior Fellow at Project Hope in Washington, D.C., with extensive experience, having been Administrator of what was then the Healthcare Financing Administration, Medicare and Medicaid, having been a Deputy Assistant to the President in the first Bush administration, and Chair of the Medicare Payment Advisory Committee. And then Bob Reischauer, President currently of the Urban Institute, but served as the Director of the Congressional Budget Office during the last go-round, and he will tell you he has the scars to prove his presence during that last debate. So let me first turn to John and have John talk with us a little bit about the Massachusetts plan, what they know, and what they anticipate happening. John.
Great. Thank you very much, Sheila. And I just want to thank the Kennedy School and the Kaiser Foundation for putting this presentation on. It's just terrific. And Julie and Barbara Whalen have done a great job in organizing the whole session, so thank you. I have now, after 70 years of life, come to realize that I can only retain about 3 things in my mind or communicate them. So I'm going to not try to give you a whole description of what we belovedly call Chapter 58 of Massachusetts Healthcare Reform Experiment, but just convey 3 items. One, that there are some successes here, so it's worth paying some attention to. I have some very, very sophisticated and Washington worldly wise colleagues to my left, so I'm sure they're going to give us some lessons in why what we do here in the sticks doesn't necessarily translate nationally, but I'm going to make that case somewhat naively. And then some of the key provisions that we've done that the Chapter 58 encapsulates and is built on that are somewhat innovative and I think are getting attention nationally. And finally, and maybe more importantly, but certainly more presumptuously, something about the political strategy. Because in a sense, the greatest thing that Massachusetts did is we actually did it. And in some ways, that's why we are getting the attention nationally that we are, because we're one of 50 states that did it. You know, it doesn't seem to work in Washington and that the rest of the civilized world already did this. But that an American province did is noteworthy. So talk a little bit about some of the political strategy, and I was more an observer than a participant in it, that has worked here. And in the next 9 minutes, I'm going to give you 3 sort of proof points of each of those 3 items, so 1 minute each. First of all, why pay any attention to Massachusetts? We have actually 2.6%, not 3% uninsured here, and every 10th of a point counts. And those are, that's a fantastic number. It's about probably 25% of what we achieved, what we started with in 2006 when health reform was passed. And these numbers are all lagging indicators for you policy wonks, so they're all, 6, 9 months out of date. But the state survey from last summer showed 2.6% on insurance. Frankly, far below what many people thought Massachusetts reform was actually going to be able to achieve. And I won't speak for the speaker, obviously, one of the architects of reform standing right here, but I hope you're satisfied with 2.6. And those are real people. I mean, those are people like Jacqueline Nicholas, who was walking around uninsured with breast cancer and without a card and without a diagnosis and without a physician until she got insured and thank God, was diagnosed, went to a physician and was diagnosed in time. And there are literally hundreds of stories like that among the 400,000 more people newly insured in Massachusetts who are alive today because that 2.6% number, while not zero, is very low. It's actually only about a point or so short of rates achieved in countries like Holland and Switzerland that also claim to have universal coverage. The second number I would throw out as a kind of a proof point is that, and this one's particularly for the policy wonks, is that 43% of the 432,000 newly insured in Massachusetts are completely privately paid for. Now, you can actually consider that good or bad, but the legislation, which was designed to develop a mixed model of public and private financing, would not have been would be even more financially challenging were it simply to have converted wholesale lots of privately insured people over to public. And that's always a fear with these kind of programs. And in fact, we've seen actually great growth in completely privately employer or self-pay insurance as well as the public programs. And then finally, we have a 75% favorability rating. And we actually have different ways of measuring it, different polls, but they all are in the same general area. That was the finding of a survey last summer by the state. Bob Blendon, who's here in the front row, is one of the preeminent healthcare pollsters in the country, every year measures this, and his measures, the last one I think was 69%, so now you have a target to shoot for next summer. And that has been increasing, but Bob tells me that the fact that it's been increasing with the implementation of reform is good evidence of the soundness of the structure that was created by the legislature and that we haven't blown it in implementing it. So those are some reasons to pay attention to what we've done here. And I can tell you that there is tremendous interest in Washington. They hardly ever invite people from the sticks to advise them. But they actually, partly because John McDonough, who's a principal architect of health reform, is on Senator Kennedy's staff precisely to bring some of his experience to bear and many of it, and his great talent in fashioning national health reform. They are paying tremendous attention to what we've done here. And three things particular stand out about what we've done. One is what's referred to as the individual mandate. Now, this is something that the Swiss actually enacted in 1996, and the Dutch enacted about the same time as we did in 2006. But it was introduced here in 2004, 2005 as a pretty revolutionary idea, and I think there were a lot of people who had a lot of trouble getting their heads around it. And clearly it is less popular than overall reform, but it is a keystone of this reform. And it has been presented in the context here of shared responsibility. So I actually think it was John McDonough and Healthcare for All and the ACT Coalition who in 2004 started talking about shared responsibility as their code for the employers ought to pay more. But it has actually, and it's been used frequently in the last 3 years to justify a sacrifice from insurers or from employers or an increase in cost sharing or enrollee contributions from individuals. And it is this rubric of shared responsibility that individual mandate is a keystone of. And we have been able to do it and do it quite successfully. There are not revolts in front of, our office fronts onto City Hall. And we have no security system. And we do all the appeals for the taxpayers who feel unfairly assessed. And despite the fears of some of my staff, we have not been assaulted. So we've shown that this very important element can be done if it's done right. And the Patrick administration has been very clear to do this generously. The legislation was wise in phasing in the penalties, but we have shown that it can be done, at least in the state. The second element I'd point to is market reform, and much of that market reform actually predates Chapter 58 and enacted in 2006. So we have, I think we're one of 5 states in the country that has guaranteed issue and guaranteed renewal. So you can get a health policy, you can get coverage regardless of whether you're sick or not, whether you have a pre-existing condition, and it's called adjusted community rating. which is too long and complicated, and I'd put more of you to sleep if I tried to explain it, but basically you can't charge old sick people a lot more than young healthy people. And still we argue about whether you can charge them anything more. But that kind of sort of pricing regulation, cross-subsidies, healthy people cross-subsidizing older and sicker people, the guarantee that you can have insurance when you actually need it is fundamental here. And we further elaborate on that reform by making the carriers offer themselves, this is to individuals in the non-group market, through a state connector. So the state has organized a market where you're guaranteed you can get coverage. And that now is very fundamental to most of the plans I see emerging in Washington. And then the third element is this connector, which seems to be universally popular. So that's pretty good indication that everybody has something different in mind when they use the word. Otherwise, you would not get that level of agreement. So it's something that's vague enough and different enough in its different formats that it has something to appeal to everybody. And I think its appeal is largely that it sounds like it has to do with the market, so that's good for the 2/3 of the population that identifies with the right side of the spectrum, and it has something to do with government sort of regulating this thing, which appeals to the 2/3 that identifies with the left side, and of course there's a third overlap. In fact, connectors can provide and certify that there are trustable, trustworthy insurance options out there, that if you buy this stuff, this 112-page contract that nobody ever reads, that it's actually going to cover you when you get sick. They can make it easy for people, individuals who don't have much expertise in insurance, and even those of us who do, to compare and shop and save a lot of money on the incredible amount of waste in the distribution of non-group insurance. It's very inefficient. And finally, in some conceptions, they can actually negotiate lower prices with carriers. So those three provisions are among the ones that I think stand out, and I hope Bob and Gail would agree that that's being talked a lot about in the Washington proposals. But I want to talk for a minute before I yield the floor to the strategy and what I call the wisdom of people like Speaker DeMacy, who crafted this legislation. And I'm sure you learned everything you know from the ex-Senate President Bolger, who's here as well. Not everything, but somebody said to me, actually it was Tip O'Neill's son, said to me when I first took this job, John, this is a campaign. This will be a campaign from the day you start until the day you finish. And I didn't really understand what he meant, but it turns out he was absolutely right. And so right now the governor, if he hasn't been rained out, is being interviewed over at Fenway Park as part of the ongoing campaign to build and sustain support for health reform. So you may or may not be aware of it, but I'm like a cheerleader for health reform. That's part of my job, and that's part of why things like the individual mandate still have some degree of support, is that we have the best brand name in New England, the Red Sox, who have a Connect to Health campaign, a Connector Day once a year, who give us hundreds of thousands of dollars of promotional support. And whether it's them, I mean, I remember stopping in at the supermarket on the way home about 6 months after taking this job, and I got my receipt, and on the back of it, it says Connect to Health, Health Connector. They're one of our corporate partners, and that's the kind of campaign you need to actually sustain this. And it is a continuous campaign. So that's lesson number one, I'd say, about strategy. There's so much temptation to focus on the act and getting 51 votes, and that's like inning one of the 9-inning game. And of course here, that was the result of basically a 2 to 3 year campaign. The second thing is that implementation is pretty complicated. You know, this is supposedly today 17.6% of our GDP, healthcare. That makes it 50% bigger than manufacturing, twice as big as education, 15 times the size of food production. It is the biggest part of American economy. And it's incredibly complicated. So you have to phase the implementation. And it's taken us 3 years to do it here. Nationally, 5 years would be very, very aggressive. And we have phased it, and that was built into the legislation. And then the final thing I would mention is we made, I think, a strategic choice here in Massachusetts to confront access before really heading into the cost issues square on. And you know, I look at for the wisdom of that, I would cite two precedents. And basically, when the Great Society legislation went through for Medicare and Medicaid, you know, they punted on costs. They said, we're going to build on the existing cost-based, third-party, fee-for-service reimbursement system. And, you know, there was no OMB. There was no CBO, and there was no OMB, and they could get away with it. I don't know if you can get away with it now, but I know that if we had decided to take on cost control at the same time as coverage expansion, it would have been at least twice, if not 10 times the fight. Now, we confront it. The costs are no more out of control than they were 3 years ago, or they would have been without reform. Now we have the moral high ground of maintaining and protecting near universal coverage from which to fight the battle that says if you want to maintain that ethical commitment, it's a road that leads directly to a confrontation with costs. And I don't know if there's a luxury to do that nationally, but I know it worked in this state. So those are a couple of lessons learned I would suggest, and now we can hear from the Washington sophisticates about how much more difficult it is, and I know it is nationally than it is at the state. Thank you.
Thank you, John. Gail?
Thank you for including me here. There is no question that people are looking to Massachusetts because first and foremost, you are able to accomplish something that other states have not been able to do, and that at the federal level we have not been able to do as of yet. There's some important learning and soul searching that's been going on by people in Washington to learn lessons from the mistakes of the 1993-1994 experience. You always have to be careful you learn the right lessons when you go back to review lessons, but I think there has been some correct understanding of not having too detailed a program come out from the White House, recognizing that there's going to be a lot of give and take, et cetera. And I think there is an interest in looking to Massachusetts, which has been able, to the surprise of many, to both pass the legislation and to keep it going, at least in its initial phases, and people do not dismiss that. I look at it as three different issues that need to be confronted, and I want to just talk for a minute on what we might be able to learn from Massachusetts about each of those three, and where the serious confrontations will arise in all likelihood as we go forward as a nation on this. The first is how to expand coverage. The second is how to pay for that expansion. And the third is how to sustain the spending that underlies the expansion and is associated with the rest of healthcare. The part where I think Massachusetts can be the most helpful has to do with that first issue, which is how to expand coverage. The notion of having the shared responsibility. The individual mandate is a very important concept. The connector or health insurance exchange has some very important ideas that underlay the availability of insurance. The blend of regulation in terms of the insurance that's offered, particularly along with a mandate and supported by subsidies so that people who would otherwise not be able to afford coverage are able to buy into that critical if you have a mandate. Those are very good lessons, and I think there are important lessons that will be picked up by Washington in all of those areas. The part that is probably less helpful has to do with the second issue, which is how to pay for the expansion. As you know, as we who are outside of Washington comment frequently, you are in an unusual position. Some of it because of your own wise decisions in the past, and some of it just because. There was some important waiver money that was going to go away if there wasn't some creative new programs that were devised. That was a very important part. The level of people without insurance was unusually low in Massachusetts, not the 15% that is true nationally. That's part because of some of the strategies that had already been undertaken by the state. And the availability of an uncompensated care pool type of money also made this, in part, easier to finance. Those were important considerations, and those are not really easily transferable. In fact, one of the real stresses that we are going to see in Washington is that this is not first up. It is earlier than the last round, where the Clinton administration did not announce the program until September 22nd, but it is not, unfortunately, first out of the box. Substantial sums of money have been spent already on a stimulus package, unfunded, and on a bailout, unfunded, and that is causing a high level of angst among some of the more conservative Democrats, to say nothing of the Republicans in the Congress. So that part really makes it quite different, the how do you pay for it. And I think people are recognizing that the third issue, that is, once you have made the expansion in coverage, will it allow you an easier time of slowing down the spending, of improving the value for the money that is spent in healthcare? Ultimately, the killer issue for healthcare in the United States, for Medicare, for the under 65 population, well, we'll wait and see. It is, I understand, a deliberate move by the state to go after access and coverage expansion first, and only then to take on the really difficult issue. But it is not without notice that we don't know whether this will actually make it any easier to take on these very politically difficult points. I think as we go forward, it may be helpful for people who are already getting up for serious battle to understand that some of the most controversial parts that appear to be on the horizon in Washington were handled in one way and not another in terms of Massachusetts. And in particular, what I'm thinking is that you really have used something that is much closer to the federal employees' health care model than, at least at the moment, is being talked about. That is, you don't have a public plan. You have regulated private plans. The fact that they were already regulated made it easier, but that is the other opposite. And of course, it is what many of the European countries also do. They don't have a public plan. They have regulated private plans. And secondly, and a point that came out earlier during the day that I hadn't really focused on, is that you delegate to the connector a lot of decision making. Again, making it much more like OPM, the Office of Personnel and Management, which it negotiates with plans for federal employees. And that may well be a very important distinction for Washington to pay more attention to than I think it has to date, recognizing that it will have to figure out where the money comes from. I don't think you can do a great society strategy of saying, we'll do it and we'll figure out how to pay for it later. Maybe if we hadn't already had these two very large spending programs that were unfunded, we might have been able to do that. I don't know, but I think it will be very hard to pull off now. But to consider the notion of pairing the individual mandate with more regulation in terms of insurance coverage, and to be willing to delegate some of the very politically difficult decisions that Congress would otherwise have to make to the insurance exchange or to whatever the state equivalent of the connector, may be a way to wave your hands and not be too specific about all the details. There's a lot of support now in Washington because nobody is talking about the details. Not the details of what will be in the benefit package, not the details of what it'll cost, not the details of how they're going to finance it, but they are going to have to get more specific. And that's in the past where we have had enormous difficulty. So I hadn't really had this insight until listening to the discussion today. But I think that may well be one of the most important contributions that Massachusetts makes, and that is delegating some of the decision-making and accountability to the insurance exchange and not having Washington trying to make all those decisions. We'll see.
Good. Bob. Thank you, Gail. Bob?
It's a pleasure to be here, and some of you might be wondering why we were ordered in this way, and it's clearly not by the alphabet or last names. It's not by height or by age, I don't think.
No, you say.
It's actually by degree of optimism. And usually I'm asked to speak first, and then, the others can pick up the enthusiasm, and the meeting can end at least on a high note. So maybe the questions will save us here. What I thought I'd do is ask the question, what can federal policymakers learn from the Massachusetts experience about crafting a viable health reform initiative, and will they learn those lessons or be able to follow those lessons? And my answer is probably no. And I have sort of 5 lessons, and the first of them is the importance of bipartisan political leadership in an effort for health care reform through a series of circumstances, not all of which could have been predicted or were logical. Massachusetts had that situation. You had a governor who was running for president, and you had leadership in the legislature that was interested and expert in this topic and concerned about it. When you have bipartisan involvement of top people, the risk for everybody goes way down. The risk of failure, the risk of conflict getting out of hand. It's not at all clear that that situation does or can exist in Washington. The Democrats clearly are united as long as the detail isn't out there. President is very, very serious about this. The leadership of the House and the Senate are 100% behind it. And the great followership is trotting along, saying all the right things. But the Republicans are largely missing in action. The leadership in the House and the Senate is quite opposed to almost all of the ideas that the President and the relevant committees in the House and the Senate are discussing. There are a few examples like the Wyden-Bennett bill, where Republicans and Democrats have come together behind a piece of legislation, but how far that will track when real bullets begin to fly, I'm quite doubtful. And when it becomes a partisan issue, a number of Democrats are going to get nervous about how far they want to go on a public plan or some other controversial element which they feel might be used in a demagogic way against them in the next election. Second lesson, which has been referred to by the others, is don't have the details specified in the legislation. Details are complex, they're divisive, they can be mischaracterized, they can be demagogued. If possible, it's nice to have extra legislative approaches where you have experts and bureaucrats, because bureaucrats have a lot to say about how to run programs, and what I would call responsible stakeholders try and work these out sort of out of camera's range, and if they bring them back to the political system for blessing or approval, it is in the form of, well, you don't like this, what's your plan that does the same thing? And that raises the bar tremendously and makes the debate more sensible. Unfortunately, that approach is really impossible to do in Washington for 2 reasons. One is that legislation has to be scored by the Congressional Budget Office, and to score legislation, you need to have the detail. So you're caught in this difficult situation where you have to have all the nitty-gritty that gets people upset before it can go up for a vote. The second reason why it's difficult to do in Washington is because the lobbying industry knows full well that their ability to affect the shape of things is greatest if it's being done in the legislature, and much less so if an expert panel or something was working it out, or a government agency like CMS was asked to work out the detail. Third lesson is go slow. Endorse ambitious goals, as you have here in Massachusetts. Lay out a path for getting to those goals, but then move at a very modest, deliberate pace, phase things in over a number of years. This makes sense because implementation is always much more difficult than politicians and political leaders think. There are tactical reasons for doing this, and there are certainly fiscal reasons for implementing and phasing in things at a very slow rate. But this is going to be very hard to do also because expectations among advocates are very high, and the supporters of reform are quite impatient. They argue, quite rightly, we've waited long enough. The planets are in alignment. Now is the time to strike. We don't want some sort of half a cake here. We want the whole thing. We want the python to swallow the whole pig, and we'll worry about dealing with indigestion over the next few years. What people forget is that several times in our recent history, the python hasn't dealt with indigestion. It's thrown up the pig. We have the Massachusetts employer mandate experience back in 1988. We have Washington State, which went through the same thing a few years later. And we had something called the Medicare Catastrophic Coverage Act, which was the first attempt to provide prescription drug benefits through Medicare, which was, before it was ever implemented at all, repealed. So you run a rather considerable risk. And yet there is such a head of steam that we have to do it now. We have to do the whole thing. And we don't want to be soft. That's going to be very difficult for that lesson from Massachusetts to be absorbed and followed in Washington. Fourth lesson is that certain concepts, mechanisms, institutions that policymakers after 1994 thought were alien or toxic, or you really couldn't go anywhere near them, really can work and can be accepted by the public if you use the right terms to describe them. And already the two previous speakers have gone into some of this. Individual mandates, employer mandates, in one view might be the powerful arm of an oppressive and intrusive government coming down and forcing things on entrepreneurs and individuals, or it can be shared responsibility, or it can be, hey, the uninsured driver is imposing costs on all the rest of us, and that's not fair. That's why we require everybody to have driver's insurance. Connectors, exchanges seem to be acceptable now. When they were called alliances, they were just, god-awful devices that Hillary Clinton had dreamed up, in the wee hours of the night to destroy the private insurance industry. The notion that we can offer folks sort of different levels of coverage and that's acceptable was sort of something that I don't think people really were considering before Massachusetts. The idea that, well, the young and vulnerables, maybe you have to make a separate deal with them to allow them to come in under a little less onerous terms, or that those people who are going to receive subsidies won't have the same kind of insurance package and choice that those who are receiving benefits through an employer-provided health insurance policy might. If those are acceptable in ultra-liberal Massachusetts, they should be acceptable in Idaho and other parts of the country. But the advocates in Washington are looking at this in a very different way. People are way out on a limb saying, as presidential candidate said, you should have available to you the same kind of health care that I, as a presidential candidate and a federal worker, have. In other words, the federal employees plan. Well, you know, that's a pretty rich plan. It's a richer plan than any I have ever had, except when I was in the government, in terms of the actuarial value of the benefits. And if we decide that we have to provide everybody sort of some level of care, of coverage that is that high up, and rather than what Massachusetts has done, the costs get sort of totally out of whack with what our ability to pay might be. Final and most important lesson from Massachusetts is undertake reform when the economy is terribly strong and don't pay for it. And there's limited applicability of this lesson at the federal level. Obviously, right now, the economy is not strong and not likely to be strong for some years. And we have a limited ability to ask the Chinese for an 1115 waiver. You know, there is this problem that the Obama administration and the Congress in its budget resolution have tied themselves to the mast of fiscal responsibility and said we're going to pay for this, not year by year, but roughly over the 10-year period. And in the current economic circumstances and with the desires that advocates of reform have expressed about the shape and nature of that reform, this is going to be very, very difficult to do.
Thank you, Bob. I'm going to give our panelists an opportunity to comment or rebut or make observations based on their colleagues' comments, and then open it up to all of you for questions. There are mics on the floor and mics up on the salmon run, so position yourselves as I give my colleagues an opportunity to ask one another questions or comment.
I have one for
You may.
Bob. As usual, I disagree with very little that Bob Reischauer says.
They're just trying to jump on the pessimist bandwagon.
I'm an economist. It comes easily.
It's not going very fast, so she can jump on pretty quickly.
What I wanted to ask you, though, is whether, given the enormous commitment that the president made during the campaign and that he continues to make, given the sizable Democratic majorities in both houses of Congress and their overwhelming commitment to this issue, at the end of the day, do you think they will be able to craft a reform package that is, as could have happened in 93, 94, if it hadn't been my way or the highway, as the only response, take this complete package or nothing at all? Do you think at the end of the day, in this first 2 years, that the Congress will be able to come up with something that is significant, but not all that is being envisioned now by the advocates, or do you think they'll just basically kill each other off on this?
I think the answer to that question lies in the hands of the strong advocates, the extent to which they will compromise, not the extent to which
Basically,
Republicans will come on.
The equivalent
Yeah.
of Mrs. Clinton last time,
Right.
not being willing to do anything other than the Health Security Act.
And you know, I think there's 50-50 chance they will.
I'd like to jump in and second that. You know, I think that if you're, you know, my background is business, and if for 50 years you have a business strategy that fails, well, first of all, you didn't exist for the last 45 years. We have a political, in this country, tremendous political energy, particularly from one half of the political spectrum, around universal coverage, and they have a dismal record. And the question is, if push comes to shove, if, for example, all you can get is a child mandate and $100 billion to let 4 more states do what Massachusetts did and line up, and now we'll have 5 olives out of the bottle instead of just 1. Will the advocates say, you know, boy, half a loaf or even 1/5 of a loaf is really a lot better than going back to ground zero, you know, the starting point and just starting all over again 10 years from now? I don't know that there's much in our history that gives us, in the history of healthcare reform, that gives confidence that that might be a realistic outcome, but it seems to me that's the kind of scenario you might be talking about, Gail.
Well, I'm actually,
And it is on the advocate side whether they can live with half a loaf.
that
if it comes to
is,
that.
I was thinking more along the lines of setting up a subsidized program for people below the poverty line, below twice the poverty line, setting up the connector idea, but not making it available to everyone at this point, mainly as a cost issue, to try to have some of the financing that will be needed, but not all of it. Bob Reich and I were talking earlier, as we were in our earlier session, that the redistribution that will go on across the country as this is fully folded in will cause very deep political stress because there are going to be the donor states and the recipient states, and that is, it is the nature of where we are in this country and how we enter the resolution of this problem, but it will not fail to be noticed. And so I don't know whether there's some kind of a set of steps that allow, in some ways it's the go slow, have a phase in, but just have a very deliberate phase in that kicks in over a 2 or 3 year period, rather than attempting a full commitment in 2009, 2010.
Building on that for just a second, and then I'll turn to our audience. There are a number of things that were in place in Massachusetts that presumably laid the groundwork for some of these things to occur, one of which was the changes in the insurance market and the market reforms. Some of those things, in fact, don't incur federal costs, and in fact are regulatory mechanisms within a state that can make a difference in terms of the affordability of what's in the private market. One might imagine a series of steps that are not necessarily those that involve federal money. Your point, Gail, that the movement around of federal funds, if, for example, you were to establish a minimum expectation under Medicaid, are those steps that might make sense? It certainly made a difference in Massachusetts to essentially move forward in terms of making insurance affordable. Could you imagine a scenario that would have some of those things occur prior to moving towards any of the big coverage steps that involve subsidies, that involve the expansion of Medicaid or other federal programs? I mean, is there a constituency that would support those kinds of things? The creation of connectors, those kinds of exchanges on a state level. Does that make any sense?
Well, just one response. I can see incrementalism by covering additional people or by doing something more in the states than nationally. The free things to do, if you will, changing the regulatory rules for health insurance and a connector, those only work, I believe, in the context of much more fundamental reform. The experience of the 5 states, including Massachusetts, that had a guaranteed issue, guaranteed renewal, and community rating is just like Massachusetts, absent other reforms. We had fewer and fewer sicker and older people in a shrinking non-group market, all of whom could, by definition, afford what they had, but most people couldn't afford to. So the rest of this reform really makes that. Yeah.
I mean, the other question obviously becomes one of scalability. I mean, the point was made earlier today that California had the same number of people uninsured as reflect the entire population of the state of Massachusetts. And so one of the challenges is to what extent can you scale? You had fewer people uninsured in Massachusetts. You'd put in place already the regulatory reforms that allowed some of these things to occur. You had some of the scenarios that Bob suggested in terms of a bipartisan leadership. To what extent can you imagine that being replicated, either state by state or in sort of a national move without the presence of those things occurring. I mean, enormous variations that exist today.
Well, I'll mention one other difference. We have costs that are 50% higher than the rest of the country. So it doesn't all run that way, but that doesn't make it easier to do Massachusetts, Texas, Florida, and Alabama in the same. I mean, starting from 4 different, and we're starting from 50 different starting points, is so much more complicated. But I don't.
Bob or Gail, anything else? And we'll turn to some of our audience.
No, I think the real question is going to be if there's a willingness to make significant change, but not 98% coverage, will there be a willingness to wrap the political arms around that and declare first round victory with more to come or not? I don't know the answer. The second one, and Bob and I have talked about this before, is will there be the foolish belief that reconciliation is the strategy to use, whereby the Senate only needs 51 votes as opposed to 60? As Bob Reischauer likes to point out, you can have this regurgitation by the BOA after the fact with its indigestion. Just because you can doesn't mean you should.
Mm-hmm. Let me start on my left. Howard?
The question that I wanted to bring up was your first point. You had 5 points, and one was about the bipartisanship. Is it possible that there's such a energy on this issue of healthcare reform in the populace in general that any pushback from the Republican Party on this issue would sort of be removed because of the concern that their own constituencies may not end up being happy about this, and in the midterm election they'll end up not having their seat, and that would be enough to overcome any of the inertia that's there?
And let me also ask our speakers to identify themselves.
Howard,
Howard, would you?
I'm Howard Zucker. I'm one of the IOP fellows this year. Thanks.
Thank you.
I think there's very little chance of that, and I turn to Bob Blendon, and I hope you haven't taken a new poll and that's going to refute what I have to say, but I mean, most Americans out there are insured and are worried about costs. Sort of as Americans and as moral people, we're also concerned about access, but we're less likely to throw our bodies on the track over that issue. I don't think the risk that a Republican runs by saying, well, you know, I don't like this because it has a public plan in it, and the public plan is going to drive the insurer that provides your employer insurer out of business, and then you're going to be forced to have something you don't like. I mean, you can spin stories out that justify your opposition. And it's not that you're opposed to health reform. It's just that you want the right health reform, and the Democrats haven't given us that, will be the argument.
Yeah, I think the issue, and Bob's polling made this point very clear during the campaign as well as now. The overwhelming issue that drives individual concern is cost in terms of what it costs me as an individual. I worry about what happens to Medicare as former Medicare administrator. Public could care less about entitlements. They're not worried in the least about Medicare and Medicaid. So I think that it's really understanding what it is that people are concerned about puts a very different spin. And even with the very strong majorities in the House, it was noted at a recent meeting we were both at that the Democrats are aware that there are 49 members who are in districts that McCain won. And so even in an institution that runs as much by the majority as the House of Representatives, they don't feel complete freedom to ignore the spending on the other side.
Okay. Yes, on the salmon run.
Thank you. My name is Elad Sharon. I'm a student at the School of Public Health. Ms. Walensky, I actually had a question about the issue of a public plan. The way that the public plan is being described in the media is essentially as a competitor, as a potential competitor to the private plans, which is part of the reason why I believe that it has a great deal of opposition, especially amongst free market advocates and the Republicans. I was wondering if this idea of a public plan could actually be, in a sense, similar to the way that Medicare actually works by essentially taking out some of the highest cost individuals away from the private market. The elderly, people who are disabled, people who have kidney dialysis, require kidney dialysis 3 times a week over the course of a year. These are some of the highest cost patients that could be in the medical system, and by taking out more such patients who are high cost, that could actually make a private market more successful and potentially more affordable. And I'm wondering if that's an idea that's potentially worth considering, or if it's one that you've heard discussed at all.
It's an interesting issue about, can you segment the market enough so that you don't have the public plan in competition with the private plan? You just described one way in terms of high cost. Another way would be to have it more for the Medicaid population, but not available for people who are employed or who are above a certain income level. That's maybe one way of having it not be the threat to private insurance that it is being considered now. The other is to not give it certain authorities like administered pricing, but there is a lot of skepticism that however it was started, if it were in fact available to the population at large, that those powers would not come around in short order. It may be, I think it is probably the most controversial issue. How do we define, is there a public plan? How do we define it? I don't personally think it's necessary, and I think Massachusetts and much of the Western world indicates regulated private insurance can be available without a public plan. Right now, it is becoming a very big component in the ideological war that is heating up. But again, at the end of the day, and I agree with the comment, whether something occurs will probably be determined by the advocates on the left and not those in the middle and the right.
You know, if I could pick up on that public plan question, I think it's a clever way of, at least people I've talked to on Capitol Hill, of getting to cost containment through administered pricing. So it's Medicare plus 10% or whatever. And I think your suggestion is an interesting one. Unfortunately, the people who are really sick are the folks who actually need the most coordination of care, and that's something that Medicare, or if that's the model for a public plan, has not really been great at. My favorite solution, since we're just an intimate group and nobody's going to be aware of what I'm saying, would be off the record, yeah, would be to give the commercial health insurers who participate in this wonderful connector access, at least as the best alternative to a negotiated rate, the same administered prices that I anticipate those who support a public plan really have in mind. And let's have all the payers have access to what, frankly, most European countries have, which is a national fee schedule.
I don't think this is the way to get...
all the providers opposed to it.
Of course, that's why I don't want any providers to hear what I'm saying.
I don't think this is likely to be the next step toward political compromise.
No, probably
No
not.
offense taken.
Probably not.
But just on the public plan, everybody's skirting over the issue of exactly how does it pay providers and what kind of network limitations does it have and how much management of care does it have. You have to say something about those things, and as soon as you do, a whole new set of battles will erupt. But I mean, I don't think, at least I don't want to create yet another entity that is a fee-for-service, all the wrong incentives system out there, which is part and parcel of the government. If we think we have to change the payment system, to change the delivery system, to get more efficient provision of care and higher quality care, we have to think about what that structure is before we put the public plan label on it.
And there are arguably questions about its financing structure, whether it's premium finance, whether there's the full faith and credit of the government to essentially back it up if it falls short. So there are a series of issues about a public financing or a public plan, that all of which suggest it's not likely to be the first issue that's compromised, would be my guess. Yes, to my right.
My name is David O'Neill. I'm a resident of Massachusetts. I pay my own health insurance through the connector. $13,000 a year for my wife and myself. We're healthy, kind of middle-aged people, which to me seems kind of high. But my question is about money, and just thinking of Watergate's deep throat of follow the money. This discussion of policy seems to be missing the idea of if healthcare costs are going to go up at the rate that everyone is predicting, and right now it's 17% of GDP, who is benefiting from these exorbitant, what seem to be exorbitant healthcare costs, and how are they going to agree to lower cost? It seems like all this discussion of policy is very interesting, but unless you get to the issue of dollars and who is going to give up those dollars, whatever the policy is not going to matter.
It was really the point I tried to make, that the overarching issue for the country is how do we slow down the growth in spending and how do we increase the value for the money that we spend. I don't even want to reduce spending. I mean, that's too much of a political battle. Just want to slow it so that we don't have spending grow at 2 to 3 percentage points faster than the rest of the economy. But that will incur the wrath of people who are used to seeing the growth in the spending, the physicians as clinicians, the hospitals, the industry, farm industry, the device industry. The 1 out of 5 jobs in Massachusetts associated with healthcare. I mean, one of the few sources of employment lately has been the healthcare area. It will have profound effects, and it is the really serious problem. Getting expanded access is important for health reasons, for moral reasons, for all sorts of reasons, but the overwhelming challenge for this country is how to slow healthcare spending growth and improve the value for what we spend. Nothing, as best I can tell, that Massachusetts has been attempting thus far begins to take on that issue. You're talking about it. We'll see what the commission comes up with. More importantly, we'll see how well it's implemented in this mecca of specialized care with high technology and academic health centers wherever you can shake a stick.
Yeah. $13,000 is an incredibly high amount. It's outrageously expensive. And, you know, healthcare in America is god-awful expensive.
Especially here.
And especially here. The interesting point is, though, that despite how incredibly expensive it is, and even more so here, we did not hold the uninsured hostage to first reforming the payment system and making it efficient. And that's an effect. You know, we have one national cost control policy now. Every year, particularly in recessions, we throw a couple million more people onto the pile of the uninsured. We ration access to insurance. That's our only national cost control policy. And my fondest hope, but as Gail says, it is a wish, it is a hope, is that having engaged in sort of the moral enterprise of saying, we're going to make you buy insurance at $13,000, that your voice will rise and add to the pressure on the people who make their living off of health care. You know, I used to do it, I guess I still do, insurers do it, physicians do it, hospitals do it. It's very hard to change the flow of dollars to people who, as a profession, save lives. But that's what we need to do, and my hope is that sort of from the moral high ground of we're covering everybody and it's outrageously expensive, we can get the popular pressure to make a dent on that.
But if you think about what we see in Medicare, that's not a very realistic hope. It may be that where we have all of the, I mean, when you need to think about is Medicare is a world where we look much more like Western Europe. We have a wage tax-based universal coverage system. We have the most fragmented care It is almost the poster child at the delivery model about how we don't want to go forward. And so while the issue about holding the uninsured hostage is not a very compelling argument, the notion that once we get people in, somehow we will be pushed to do something, it's like, I mean, if anything, it has made it even harder rather than less hard. Now, I don't think that that's a rationale for not going forward. We need to get that part of the problem resolved. We just shouldn't fool ourselves that it's going to make it one whit easier to go after the spending increases and the problems in value.
And it's hard to imagine on a national level in this discussion that the feds would be in the same position Massachusetts was in, which was to choose to do coverage before having dealt with costs. At least one would imagine, given the circumstances, that it would be a harder sell at that level. But again, unclear. Bob, did you want to comment as well?
Thank you so much for being here. My name is Shira Epstein. I'm a Master's in Public Policy student at first year. You've all spoken a lot tonight about the trade-offs, especially the policy trade-offs between choosing coverage versus choosing cost. And that's something we've learned a lot about in our first year curriculum, both in healthcare classes and also in general politics classes. And what we talk about is how the political trade-offs and political fallouts don't necessarily match up with the best choice for policy. And so I'm wondering on a national level, in terms of if you really had to pit choosing universal coverage against choosing cost containment for the Obama administration, which would he have more political capital to address? And should he choose one or the other, what will that mean in 4 years if he's looking towards re-election?
Well, if you actually look at what people say bothers them, it's the cost that they face as individuals. And if there was some way to figure out how to address that, it would have, as I look at the polls, a lot of political capital. I think the problem that the administration is facing is not that it doesn't have the enormous desire to expand coverage, but that this is coming third after having two large unfunded other packages. And so the problem is, where do you get the money to pay for this? Because the administration is being quite serious about being fiscally responsible, and they also have already probably shot their wad on what they could do justifiably in terms of unfunded spending. So it's not even, in some ways, we're having the wrong discussion about, is it expand coverage or moderate spending? It's expand coverage if you can come up with a way to finance it. But there are only so many ways of hitting the over 250,000 income individuals that appear to be likely at the moment. The way the Obama administration chose to finance their down payment, which was to limit their deductions, was declared DOA by the chairman of the Senate Finance Committee. Now, there is nothing that is deader when it comes to a tax change than having the chairman of the Senate Finance Committee say, no how, no way, come up with something else. So it's really, I mean, I think people aren't saying, let's figure out how to slow spending before we expand coverage. It's, you have to figure out how you're going to pay for it. And as my friend here said, probably the Chinese are not going to finance our 1115 waiver.
You know, some of you might think it's hard to be more pessimistic than Gail's been, but let me give it a try here. You know, and I think both of these choices don't get the administration anywhere. It goes for the cost containment. We're going to hold down the growth of costs, and rather than growing 6.5% a year, we're going to bring them down to 4.5%. And all of us wonks would just be ecstatic. We'd say, you know, whoa, long-run projections, this is what we need to do. You think Harry and Louise, you know, are going to be satisfied? You think the newspaper stories about so-and-so having cancer and, you know, not having enough money to buy the drugs are going to stop? No, they aren't. And so people, you know, aren't going to look at this and say, you know, wow, that Obama administration really came through and did it. You know, we will, but we don't account for anything. On the other hand, if they did the access route and expanded coverage, but it was not the whole enchilada, and what we did was lower the number of uninsured from 45 million down to 38. But then we have to factor in the fact that we're in a terrible economic decline, and it's going to be rising at about 2 million a year. It's really going to go down from 45 to 44. And people are going to say, you didn't do anything, even though we'll run our models and we'll say, God, there really was a net decrease in what would have otherwise been 7 million people. And so I think it's a very, very difficult situation if you're just thinking of raw political reaction to what takes place.
Bob, I think you've succeeded in being more pessimistic. You know, as a guy who's usually accused of being cup is half empty, I'm feeling hyper liquidated here. But I would guess I'd suggest that whether it's 38 or 30 million or whatever, he's going to get, you always get more political benefit out of insuring people than trying to control costs. I mean, that's the ugly reality.
Yes.
I'm Leo Stolback. I'm a physician who...
Hi, Leo.
Hi, John. John knows what I'm going to say.
I already know it. You want me to give the talk?
I worked in Canada as a physician for 3 years in the early 80s and saw how well a single-payer or Medicare for all system could work. And I want to say right now, because a lot of people have a misconception that the Canadian system is not socialized medicine. The physicians do not work for the government, and patients have a choice of physician and hospital. I saw how well that could work, and what I'd like to hear from the panel is why the single-payer approach, when you consider that the multi-payers cost a lot of money in terms of administrative costs and overhead costs. In Massachusetts, it was found to be 39% when there was a study done in 2001. A lot of people poo-pooed this and said that that was excessive, and California came out with the figures of 34%. Now, the insurance companies, they have reasonable overheads. They claim to have somewhere between 8 and 12%. But what it doesn't take into consideration is the downstream costs to the doctor's office and to the hospitals. And that's where this total of 34% of the healthcare dollar comes up. And what I'd like to ask the panel is why not go to a Medicare for all system? And one final comment, you know, when Obama administration came out with the healthcare summit, it turns out that there was not one person that represented single payer that was in that 120 that were invited to that. And it wasn't until a group of us lefties contacted the White House, and they finally had Representative Conyers, who has a bill in Congress that's a single payer bill, and the head of Physicians for a National Health Plan were finally invited to the summit. So I'd like to hear your comments on why we can't go to single payer now.
Well, mine's pretty simple. I think I've actually said it to you before, Leo. I'm not willing to hold Jacqueline Miklos hostage to going to single payer. So Jacqueline is alive now because she has coverage. There are 430,000 people in Massachusetts who are better off because they have coverage.
Oh, yeah. No.
And if I thought that it had 1 in a 10,000 chance that you're going to put a $1 trillion industry out of business like that you're going to take 17 to 18% of our GDP and completely revolutionize it. You know, when England nationalized their healthcare system, the healthcare system was completely bankrupt. It had been literally bombed by the Nazis, and it was 1/150th of the size of our healthcare sector. So I'm not willing to hold Jacqueline Miklos hostage to that vision. I just don't think it's realistic.
Yeah, I mean, I think that this is a purely political decision about whether or not the country wants to have 2.2 trillion, 2.4 trillion, whatever the current number is that we're spending on healthcare, be under the aegis of the government. And it's not a question of having the physicians directly employed by the government. It's the amount of government control that suggests. And I think politically it should not be overlooked that none of the serious candidates talked about a single payer as something they thought was politically viable in this country at a time when there was a clear movement to the left of where the country had been politically. So I just think it is an issue that this is not a politically viable situation in the U.S. at this stage in its history. I would think actually not likely, although universal coverage is very much a possibility for the country, not a single payer in my mind, again, on the politics. I'd like to remind people, though, that as important as Medicare has been for the elderly, as many good things that it has been able to accomplish in terms of what many of us would regard as the fundamental problems of healthcare in this country, which is unsustainable spending and not getting value for the money that we spend, not having the kind of a delivery system that produces clinically appropriate, accountable results, Medicare is not one whit better than the private sector, and if anything, even more fragmented by its increased focus on a la carte fee-for-service medicine than the rest of healthcare. So Medicare has been able to do one thing really well. It has made sure that seniors have access to insurance coverage, and I don't want to belittle that, but it has not been able to do very much when it comes to addressing these very fundamental questions with the American healthcare system.
Couple of points. One is that Medicare's performance in a mixed system where it accounts for 20% shouldn't be taken as what its performance might be if it were the whole enchilada. And I think a lot of what you say needn't be true in that system. There's sort of a couple of questions here. One is, if I could press a button and have a single payer system or 45 million people uninsured and the growth of cost that we have now forever, I'd press the button. Politically, I agree with the others that we're much more likely in our democratic decision-making system to go for a different solution, a Dutch solution, a Swiss solution, one of the others. I have a farm in Canada, and I've received care at the local hospital and from the local physicians. I like it a lot, but the information from the Commonwealth Fund suggests that on a number of quality measures, the only major country that ranks lower than the United States on many of these is Canada. And a lot of this is sort of how much they're willing to spend, but
They spend half on a per capita basis as we do.
well, I mean, these are comparisons against Great Britain and Switzerland and other countries like that, where that's not the case.
I do think the point that there are lots of countries that have pluralistic systems that are a whole lot more efficient than ours. I'm not defending our system, but there are politically more viable ways to get to where you want to get to than the single cry of single payer.
I mean, if you don't want to hold universal coverage hostage to cost control, I certainly don't want to hold universal coverage or 98% coverage hostage to single payer. I mean, that is just not a good trade-off for this country.
We have a couple of folks waiting, and we have about 3 minutes. So I'm going to very quickly ask you to ask your question short, so that we can get a quick answer from our panel and then
Can I be heard?
deal with a couple
Okay.
of our colleagues. So
I'm a graduate of public health school way back in 1983. And that year that I spent in the school completely changed my life. And I could practice health sector reforms in countries outside the US. and my entire life has been invested in that initiative. I was inspired this morning by His Excellency de Macy to attend this forum this evening. And I'm really thrilled to see that certain things which we have practiced worldwide are coming to the fore in this part of the world, which claims to have the best of standards in delivery of healthcare. I'm not saying best of access, but best of standards. I have a comment to make which is very valuable to me, and I would like to share that in different economies, we know for sure that the healthcare level of healthcare attainment depends heavily on the economy. And US enjoys a different level of economy than most of the countries. However, healthcare spending, allocation, and utilization depends on public policy in every state. And also the way healthcare is developed and distributed and accessed also depends on public policy. So wherever there is a reform initiative being undertaken, whether it's in a developing economy or in a developed economy, have had the basis of public policy as fundamental initiative to bring in these reforms. Now, very, very significantly, we've talked about universal access. We've talked about, let's talk about, there was a mention about equity. We are talking of equitable access. And we are also talking about continuum of care. It is not necessarily that the patient comes and sees the doctor and takes medicine and goes away, but we are talking of continuum of care, from promotion to prevention to cure and to rehabilitation. And I think we are focused on that situation. Now, my comment is ending here, and I'm going to raise a question. Worldwide, when we see that the issue is of financing and provision of healthcare, and when you get access, it is both financial as well as physical access. The moment we increase access, financial access to healthcare, you'll see that there is a sudden spurt in the demand for healthcare. And now, most countries, if we leave it to free market economy to fill that gap, we'll continue to face the problem of high cost, high delivery of care. Now, is there any policy initiative being taken in this country where we are incentivizing investment in healthcare so that we can build capacity both for provision, capacity for training, and also bring about the sea change that we are talking about, one patient, one record, so that we save so much of cost of replication and duplication of services? Is there any initiative being taken in the public policy at this moment? Sorry for raising such a, giving a comment, and thank you very much. I cherish having been to this school, and I, again, thank you so much.
Thank you.
Well, we'll see whether the investment that has been included in the stimulus package of $19 billion to go for the development of electronic medical records is able to provide that impetus. Some of us are a little worried about the lack of standards and definitions that exist now, which would severely limit the ability to reach into those medical records and get information on comparative effectiveness and appropriate clinical outcomes. But those are issues that can be solved.
I'm going to apologize to our two remaining and ask if you want to come up afterwards and ask a question. I think
it's a good point. My name is Michael Latique, with an A, from Boston. My website, m-eek.com. I've been proposing for over a year now that our soldiers that are injured in service need to be fully covered for the rest of their lives. That has to be the given. On the other hand, the historic precedence for the Veterans Administration doesn't seem to hold viability anymore, and it seems to bog down. It seems to bring our politicians into looking in different directions as to where health coverage is going to come from. I'm wondering why this hasn't been proposed, and do you think if it's feasible?
It is the...
I was going to say, Gail has actually been involved in looking at exactly this issue.
Those that are injured in either Afghanistan or Iraq or anywhere else do have access. They have immediate access through the veterans.
They have full coverage, but what I'm saying is that the coverage needs to be privatized. It needs to be insured for the rest of their lives if they're injured. But on the other hand, the VA system could be absorbed into the private sector.
Well, just as it happens, other countries that have universal healthcare systems do not have separate VA healthcare systems. My prediction is over time, not any time immediately, if we get to universal coverage, it is likely that we will find a different use for the VA system, and that except in areas where there is no physical facilities available, you will see individuals receiving care in whatever is the dominant healthcare system. That is true for Canada, it's true for the UK, true for other countries. So I think that would happen along with universal coverage.
Please join me in thanking our panel.